Hello and welcome to Module 2 of Introduction to Mechanical Ventilation. Today we will be going over ventilator settings. When looking at ventilator modes, I think the easiest way to do education on modes is looking at pressure modes versus volume modes. With volume modes, you have a tidal volume reading that you're setting on the ventilator. This is usually a 3-digit value, and 500, let's say, is typically the average volume you're going to see for patients. And if you can see this as like, let's say, a fluid in a container, it just measures the milliliters in the lungs that are going to be exchanged. Volume modes consist of pressure regulated volume control, or PRVC, VC, which is volume control, and VS, which is volume support. Depending on the mode or the ventilator you're running will depend on the names of these modes. If you're running a Puritan Bennett or any other mode, you're probably going to have different names for it. It's proprietary to the ventilator model, and that's how they decipher some of these things. But fundamentally, they typically have the same modes. In pressure modes, you're going to have pressure control, APRV, or pressure support ventilation. And APRV is another name for bivent, which is usually used for oxygenation. These values are something you set on the ventilator, not to be mistaken with last week's or last module where you're setting the numerical values. These are mode values, and they'll have different dynamic features in them that you will be setting. Once you understand if you're running a pressure mode versus a volume mode, the next thing to look at is, are you running a control or a support mode? SIMV is a fancy acronym meaning synchronized intermittent mechanical ventilation, or mandatory ventilation. In all it means is control with support. So you're going to have control, which means you will have a set rate and an I time, but you will be setting a pressure support, and that will only matter when a patient triggers a breath. This graph I placed here would be a ventilator that is not quite set appropriately, but you can see that the amplitude of some of these waveforms right here versus right here are different. The screen says pressure support for the smaller amplitude breaths and machine or assist breaths for the larger amplitude breaths. This would be a situation where the control is not lining up with the support. A lot of times in volume modes, volume control modes like PRVC, a therapist will measure 500 tidal volume, but have a pressure support that is set low, and the tidal volume will be 400. You figure this out by measuring the change in pressure from the PEEP to the peak inspiratory pressure, and that should be your pressure support, which would make it even amplitude from breath to breath to breath. When determining settings that you're going to place a patient on when they first go on a ventilator, it is important to know the appropriate values of a normal person and then make adjustments based upon when you're going on a ventilator. I cannot stress that a spontaneous breather more efficiently controls their body and their arterial blood gases better than a control breather. So the moment you're taking away their spontaneous breathing to place them on a ventilator, you're probably going to need to give them more ventilation to suffice the spontaneous effort that you've taken from them. When setting a tidal volume, there are two factors that matter. It is the patient's gender and their height. I don't know how well you can see the chart, but based upon gender and height, we have a female and a male chart. You would look at the height, you would trace it over, and you would find the milliliters per kilogram ideal body weight that you're going to run. And from there, you would find a patient's tidal volume. Normal respiratory rates run around 12 to 20, depending on a patient's arterial blood gas that you might have before you place a patient on the ventilator. You would adjust this accordingly compared to the rate they had before they came on a ventilator. Normal PEEPs for a patient often are determined by the facility that you work at. It's kind of an unspoken rule. Some hospitals have policies that manage PEEP values. Normal, walking around, you and I have a PEEP of 5. Patients with larger body habitus have created autonomic PEEPs of greater values. Typically, when you're placing a patient on for respiratory failure or anything like that, you're going to run PEEPs of 8 to 10 to 12, depending on oxygenation, or even higher if they have ARDS. Oxygen's usually predetermined by an arterial blood gas, or started off at 100 to 80% and weaned from there after blood gas monitoring. I time, if a patient's spontaneously breathing, I time controls flow. So a patient with a long I time that's spontaneously breathing may not like the long I time, and they want shallow or smaller I times, which would create faster flow into the patient. Patients that are not spontaneously breathing usually benefit from I time in the fact that you're doing small breath holds from breath to breath to breath, and it helps recruit alveoli, just like PEEP does. And then pressure support is not going to matter unless you have a spontaneous breather. So pressure support does not even matter unless the patient spontaneously breathes. Even if you're on SIMV, synchronized intermittent mechanical ventilation, if your patient doesn't have spontaneous effort, then the SIMV does not matter. That means you're just basically in the control mode of the mode you're in. To expand on tidal volumes and how we set them, so typically when we place a patient on the ventilator, the patient does not have normal lung function. Let's say they were intubated for a procedure or airway protection or anything like that. That's going to be your patient that's more than likely got more normal lung function. And literature supports that patients with normal lung function should be ventilated at 6 to 8 milliliters per kilogram of ideal body weight. When you're looking at ARDS patients, it is very important to follow ARDS-NEC protocol, which I've displayed to screen here, that recommends PEEP values based upon FiO2 that's being delivered or oxygen, and using low tidal volumes, usually 4 to 6 milliliters per kilogram of ideal body weight, to reduce volume and barotrauma in the patient. Large tidal volumes on these patients with stiff lungs will create lung damage, and that is something that is very pertinent in critical care medicine and has been heavily studied and is continually argued still to today. Depending on disease processes, you might change your tidal volumes. COPDers usually run 4 to 8 milliliters per kilogram. Pulmonary fibrosis, you usually run lower, more like ARDS protocol due to the bad lung compliance. It's really going to vary based upon the disease process as well. But it's important to know that normal lung function runs 6 to 8 milliliters per kilogram, and ARDS protocol calls for 4 to 6 milliliters per kilogram. Depending on disease process, you're going to vary from that gap of 4 to 8, maybe even 10 milliliters per kilogram. This is not to get confused with spontaneous breathers. So this would be more controlled breathers that have no spontaneous effort. A lot of times the medications we give in intensive care medicine create a respiratory pattern of low rates but high volumes. These patients are using muscles to accommodate larger volumes and dramatically reduce the risk of volutrauma, barotrauma. The only population I have seen patients hurt their lungs from the spontaneous effort is COVID patients and pulmonary fibrosis patients. These patients have bad lung compliance, very stiff interstitial spaces, and their respiratory efforts in taking massively deep breaths create a lot more scarring and a lot higher probability of a pneumothorax. I've seen quite a few patients I personally worked on that have received pneumothoraxes from large spontaneous efforts. These were initial strands of COVID where patients were being placed on a ventilator at a higher rate. In more recent rounds of or mutations of COVID, there's been less use of mechanical ventilators, and they have been intervened upon before they get that far, which is a great thing. In a prior slide, I talked about understanding compliance based upon modes. This is just a touch up with that, but one of the main ways you're going to understand it is through peak inspiratory pressure. And peak inspiratory pressure is going to matter when you're in a volume mode. In pressure modes, you look at tidal volume. I can't stress that enough. I see a lot of people forget that concept whenever they're managing ventilators. The other thing is lung compliance can be measured in a multitude of ways. A lot of the MBRC, your accrediting body exams, look at plateau pressures, which calculate into static and dynamic compliances. You need to know these for your MBRC exam, static and dynamic compliances, and those we will go over in another module. But the values that go into that are often peak inspiratory pressure, PEEP, and your plateau pressure. And plateau pressure is the measurement of the pressure at the alveoli. Peak inspiratory pressure is the measurement in your large airways. So if you have a high peak inspiratory pressure and a low, usually -5 from your peak inspiratory pressure for a plateau pressure or alveolar pressure, that means you have a problem in your large airways, which could be bronchoconstriction, mucus plugging, anything of that sort. It means a lot of airway resistance. If your peak inspiratory pressure and your plateau pressure run very similar pressures, this means you have a bad lung process. So you're at higher risk for ARDS or pulmonary fibrosis or anything like that. This is a classic way and an easy way to figure out lung compliance that I do not see therapists use often and take for granted. But it will be studied, you will have to study this, and it will be asked to you on your MBRC exams. Other compliances, when you get more familiar with these values, you can know what the static and dynamic compliances are going to be just because you know normal values for peak inspiratory pressure, PEEP, and plateau pressure. And if those numbers are going in high into your static and dynamic compliances, chances are your static and dynamic compliances are going to be reading bad.